going to give you some my experience about the treatment of long CTO FEMPOP lesions. My disclosures. So we should know first that according to the ESVS guidelines, the femoral lesion superior to 25 centimeters should be first treated by open surgery, and that endovascular treatment is performed if the patient is unfit for open. My femoral algorithm to treat femoral lesion, long femoral lesion, is first to assess the patient, because it's different if you have a CLI patient and claudical patient, to assess the runoff, to know if the patient is a diabetic patient or not. But also we should assess the type of the lesion, if you have a de novo lesion, restenosis lesion, if the length of the lesion, the presence of calcification, and also the reference vessel diameter. After that, we have to cross, of course, the lesion to perform the vessel preparation and finally to treat the lesion. First, these long lesions as C and D are still challenging case. Why? Because they are long first. In many cases, the popliteal artery is involved. We have difference between de novo and restenosis, and we have also calcification. It's challenging lesion because of clinical issue. In half of the cases, patients are CLI patients, and finally they are challenging due to technical issue to deal with the entry and re-entry, to deal with intra or subintimal recanalization, and with long devices to treat this lesion. First, what I used to do, I do this lesion in outpatient hospitalization. I don't use conventional hospitalization to treat this patient. And if you look the data about ambulatory, there is no contraindication to treat this long and complex lesion by ambulatory management. Secondly, I used to perform a retrograde approach using a duplex kind-guided femoral puncture. And usually I start with a long 45 centimeter sheath, 4 to 7 according the devices and the cases. Also, I use fusion software to help me during this procedure, and I start by a bolus chase to confirm the CT scan or the MRI data, and also to visualize the level of the re-entry. And in this case, you can see the re-entry between P1, between P2 and P3. First, then we perform the crossover using the fusion. You can see that we use, in this case, UF catheter and a stiff pterymo guide wire to perform the crossover. And then we have to catheterize the SFA. In some cases, you can see here that the stump, we have no stump, in fact, but it's not a big deal. We use, in this case, the vertebral catheter, the stiff guide wire, and we enter into the first centimeter of the SFA. After that, we have to choose between intraluminal and subintimal. I don't give you some detail about that because it will be the next presentation. But in routine cases, I used to perform a subintimal or intraluminal using a loop by a stiff guide wire, the same that the crossover, so we save cost also to cross the lesion, or 35. After that, we have to perform the re-entry. And for example, here we use a blue circle to locate the level of the re-entry. And when you perform the re-entry, you push the loop and you remove the loop using the balloon catheter, and you push then some contrast product to check if you are in the intraluminal space. If you fail to make the re-entry, I don't use re-entry devices at the FEMPOP level. I use in this case some retrograde access using some micro puncture kit, for example. And in this case, I make the puncture at the P1 level, but the most easier case is to make the puncture at the anterior tibial artery, even if the patient is a claudicant patient. So we perform then the vessel preparation, and then you check the results of the vessel preparation. It's very important to check the result of the vessel preparation because in some cases you are not able to deploy the stent, and then you have to use some homemade atherectomy devices in order to enlarge the lumen. So check the results of the regular vessel preparation by balloon before implanting a stent, DCB, or DES. So my colleague gives you some many tips and tricks about the treatment, about the vessel preparation and debulking in this case. So after that, we have to treat this long lesion. We have many tools to treat this long lesion. Again, my colleague gives you some tips and tricks to use these devices, but so far you can see that in many cases we need scaffolding because we have many classifications. It's very difficult to assess this long lesion. But to set up the algorithm of treatment, we have many randomized clinical trials. In fact, we have many cohorts for long lesion, cohort for DES, cohort for BMS, cohort for DCB, but we have only 2 RCT to know, which published RCT to know more about the long femoral lesion. And this RCT has been performed with the Viaban versus BMS, the ViaStar study, and in the Superb, they compare the Viaban versus the open surgery. So to conclude, endovascular repair of long fempop lesion is indicated in patients unfit for surgery. I should say that in regular practice, I treat by endo in a first line of treatment this lesion. Primary endovascular therapy of task C and D lesion needs undergoing surveillance and longer follow-up given the high rate of CLI patients, the risk of thrombosis or restenosis, and definitely trial should figure out what is the best device to treat the right lesion. Thank you for your attention.